Hello and welcome to the 2021 Virtual Prevent Cancer Dialogue. My name is David Berrigan. I'm a program director in the Behavioral Research Program of the Division of Cancer Control and Population Sciences at the National Cancer Institute and a longtime member of the Foundation's Research Grant Review Panel. I have no conflicts of interest relevant to this panel, but I'm delighted to serve as moderator on behalf of the Prevent Cancer Foundation's 2021 Virtual Prevent Cancer Dialogue. And it's my pleasure to introduce our speakers today, who are three really interesting researchers working on tobacco control at multiple levels. First, Dr. Francisco Cartujano Barrera is a research assistant professor at the University of Rochester Medical Center and served in 2017 as a research fellow at the Instituto Nacional de Salud Pública in Mexico to expand the use of mobile tools for smoking cessation in Mexico. His work on smoking cessation for Latinos is very timely, and I really like the effort to address smoking cessation across borders, given international mobility and the opportunity and chance to learn from other countries. Second, Dr. Darren Mays is Associate Professor, Division of Medical Oncology at Department of Internal Medicine, College of Medicine, the Ohio State University Cancer Control Program in the Ohio State University Comprehensive Cancer Center. Dr. Mays is really pushing the envelope in the area of mHealth interventions and more sophisticated understanding of communication and messaging around tobacco use. Third, Dr. Minal Patel is director at the Schroeder Institute Truth Initiative, where she examines the impact of tobacco control policies on health behaviors with an overarching goal of understanding and reducing related health disparities. Dr. Patel was a cancer prevention fellow in our program, and it's fantastic to see how rapidly she has grown into a national leader in understanding policy approaches to tobacco control. So this should be a really interesting set of speeches, and we'll have an opportunity for questions at the end. We'll wait to address such questions until all the presentations have been concluded. You can ask questions and comments in the Q&A tab of the engagement tool on the right of your screen. So let's get started with the first presentation from Francisco Cartujano, who will be followed by Darren Mays and then Dr. Minal Patel. Thanks so much for your attendance.
Hi, my name is Francisco Cartujano Barrera. I'm a research assistant professor at the Department of Public Health Sciences, part of the University of Rochester Medical Center. The name of my presentation is One Text at a Time, Promoting Smoking Cessation Among Latinos. I have had no relevant financial relationship or conflict of interest within the past 24 months. And this is the agenda for today. We're going to start talking about tobacco-related disparities in the U.S. We're going to talk about some community-based approaches to address these disparities. We're going to talk about cultural and linguistic adaptation of interventions for Latinos. We're going to talk about the use of mobile health for smoking cessation among Latino smokers. And I'm going to talk about the work that I have done for Latino smokers living with HIV. In this first slide, we can see the percentage of adults who are tobacco users by race and ethnicity. We can see that there's a group that has really high percentages of tobacco use, and those are American Indians. We can see that 31.8% of American Indians use tobacco, and there are some differences by gender. We can see that American Indian men smoke at 29.3% compared to American Indian women who smoke at 34.3%. Then we can see that there are two groups who have very similar percentages of tobacco use, and those are whites and blacks. Whites have a 16.6% of tobacco use, and blacks 16.5%. And there are two groups who have relatively low percentages of tobacco use, and those are Hispanics and Asians. Hispanics with 10.7% and Asians with 9%. However, when we take a closer look at Latinos, we're going to see that there are some particular group who have really high percentages of tobacco use. For example, if we look at Cuban men between 50 to 59 years old, we're going to see that around 40% of them use tobacco. And then if we see at Puerto Rican men between 30 to 49 years old, we're going to see that, again, 40% of them use tobacco. Then we're going to see that there are some groups like Mexicans and Dominicans in where the percentage of tobacco users is relatively low. Now, I'm building up the case on why we need to do research among Latino smokers. First of all, we need to understand that Latinos represent 17% of the total population. But by 2016, we're going to represent 30% of the total population. So the number of Latinos are increasing. We also know that Latinos are less likely to have access to healthcare. Latinos are less likely to receive advice to quit smoking. Latinos are less likely to use counseling and medication for smoking cessation. And Latinos are less likely to participate in studies for smoking cessation. This low participation is due to two factors. One is because not all the studies are available in Spanish, and we do know that for us to enroll Latino smokers, we do need to make the studies available in their language. We also know that Latinos are what we call non-daily or light smokers. The definition of light smokers are those smokers who smoke less than 10 cigarettes a day. Most of the clinical trials require participants to smoke more than 10 cigarettes a day, and by having that eligibility criteria, a lot of Latino smokers are not eligible to participate. The work that we do and that I'm going to talk about is framed around participation of community key stakeholders. In this slide, I'm just naming some of the people who have worked with us for the past 5 years in making sure that our intervention is culturally and linguistically appropriate. We know that the clinical practice guideline recommends the combination of counseling and medication for smoking cessation. It is our responsibility as public health researchers to make sure that both counseling and medication are delivered in an appropriate and innovative ways. And here we have some fun facts. We know that 80% of adults use text messages. We know that 90% of adults who use text messages read their messages within 3 minutes. And we know that 91% of those 80% adults who use text messages keep their phone with them 24/7, even when sleeping. So knowing these fun facts, we partnered with a company that is called Agile Health. Agile Health is a company that provides text messages for behavior change. So we did a pilot study with 50 Latino smokers in where they were enrolled in a text messaging live intervention for smoking cessation. This intervention was culturally and linguistically adapted, working with a community advisory board. Some of the key results are that 100% of participants requested nicotine replacement therapy, which are some medications for smoking cessation, at baseline. This result is particularly important because a lot of literature has said that Latino smokers are not interested in using medication for smoking cessation. So this study exemplifies the importance of offering the medication in a culturally appropriate way. And if we do it that way, then participants are going to utilize it. We also learned that participants love interacting with us, and I'm going to show in a little bit some of the examples in where participants interacted with us. And surprisingly, at week 12, 30% of participants quit smoking. Also, participants reported high satisfaction with this intervention. So what we learned through this pilot study is that text messages for smoking cessation are appropriate, feasible, and highly acceptable. These are some of the examples in where participants interacted with us. We had an automatic message that says, I am 38 years old and I have 3 small kids. I want to quit smoking to spend more time with my kids and someday meet my grandchildren, Maria. So this is a testimony that was sent to participants. And these are some of the responses that participants sent to us, even knowing that the messages were sent by a computer. Maria, God bless you. We should pray to God that He will get us through our addiction, and I hope that God blesses you and your family. Have a good day. Good, Maria. I have a grandson, and when he sees me smoke, he tells me that I'm losing minutes to my life. I want to have more time with him. So something that we were also able to do is to analyze the messages that participants were sending us, and through that, learn what is appropriate, and we can see some of the cultural values that Latinos share. Based on that pilot study, we're currently conducting a randomized clinical trial that is called Decide Texto, Mobile Cessation Support for Latino Smoker. My mentor, Ana Paula Cupertino, is the principal investigator of this study. And this is a study that we're doing in partnership with Hackensack Meridian Health in New Jersey, the University of Kansas, Children's Mercy in Kansas City, and Georgetown University. So the aim of this randomized clinical trial is to evaluate the impact of Decide Texto, a culturally accommodated program for smoking cessation, compared to standard of care on smoking abstinence at month 6 among Latino smokers. 457 participants will be enrolled in Decide Texto, and half of them are going to be in the control group. The control group consists of educational materials for smoking cessation and access to nicotine replacement therapies. The other half of the participants are going to be in the intervention group, or Decide Texto, and they're also going to receive the educational materials for smoking cessation, access to nicotine replacement therapy, and an intervention that we call Decide Texto. Decide Texto incorporates a tablet-based decision-making session, and I'm going to show you in a little bit some of the screenshots, and then a text messaging program for 6 months. These are some screenshots of the session participants using the tablet. Some of the questions we ask is for them to identify their main reasons to quit smoking, to identify why they smoke, some strategies whenever they're facing those triggers. We ask them to set up a quit date. We explain to them the importance of using nicotine replacement therapy products, and we ask them to select which one they want to use, and they also get to see a testimony. Then our text messaging intervention is a library that consists of 712 messages, and one of the key elements of this library is that we do the management of nicotine replacement therapy. What do I mean by this? We manage side effects, dosage, we troubleshoot any problems that participants may have with the medications, and this way we're making sure that they are adhering to the medications. We also have an algorithm in where we recognize if people relapse, and if they relapse, then they go to a track that we call the relapse track, in where we work with participants to select a new quit date and do a new quit attempt. Something we're really proud of is our reliability scores. We have our messages at a 3.9 readability score, which means that someone with a 4th grade level will be able to understand our messages in English. And in Spanish, our readability score is 77.4, which means that our intervention in Spanish is easy to very easy to understand. Now, I have talked to you about the pilot study we did with 50 Latino smokers, in where we show that text messages for smoking cessation are feasible and acceptable among Latino smokers, same as the use of nicotine replacement therapies, and how that led to a randomized trial in where we are evaluating the efficacy of this intervention. So what's next? Part of the recruitment that we have done for this randomized clinical trial is partnering with community-based organizations. And one of our key partners are organizations serving people living with HIV. Now I'm going to present to you the work that I've been doing through a grant funded by the Prevent Cancer Foundation. First of all, I want to talk about some statistics when it comes to HIV. We know that Latinos represent 16% of the US population, but we also know that Latinos account for 25% of all new HIV cases in the US. We also know that antiretroviral therapy has increased life expectancy. However, we're seeing some increases in cancer, especially in lung cancer, and this is very alarming to us. One of the key factors for this increase of lung cancer is that smoking rates among people living with HIV are higher compared to the general US population. We know that among the general US population, 19% of adults are tobacco users, compared to 40% of people living with HIV. And we also know that there's evidence showing that people living with HIV are less successful in quitting smoking. And we also know that among Latinos living with HIV, 35% of them are tobacco users. So all this is the rationale on why we do need to make interventions specifically for Latinos living with HIV. So these are the specific aims of the project that I'm doing, funded by the Prevent Cancer Foundation. The first one is to develop a smoking cessation text messaging intervention tailored to Latino smokers living with HIV. The second aim is to determine the feasibility, acceptability, and preliminary abstinence rate of this new intervention among Latino smokers living with HIV. And the study is divided in 3 phases. The first phase is to conduct semi-structured interviews with key leaders of community-based organizations and clinics serving people living with HIV. The second phase is to conduct a user-centered design research with Latino smokers living with HIV to test the features of the text messaging intervention. And the third phase of the study is to conduct a single-arm pilot study with Latino smokers living with HIV. What do I mean by single-arm pilot study? Meaning all participants who are going to be enrolled in the study are going to receive the text messaging intervention. So talking about the semi-structured interviews with key leaders of community-based organizations and clinics serving people living with HIV, the objective of these interviews was to understand the barriers and facilitators of smoking cessation among Latinos living with HIV. So here we have the barriers and facilitators organized by level. We have barriers and facilitators at the individual, interpersonal, organizational, community, and policy level. Some of the barriers we identified at the individual level was a minimal understanding of the benefits of quitting smoking. Some of the facilitators that people reported is that people living with HIV are highly interested in participating in clinical trials and research studies. Another facilitator was that people living with HIV have good medication adherence. At the interpersonal level, some of the barriers were the language barriers. Some of the people we interviewed reported that at their clinic or organization, they do not provide smoking cessation counseling or services available. They don't have them available in Spanish. So this is a barrier for Latinos to receive counseling for smoking cessation. Another barrier was low social support, either for friends or family. One of the facilitators at the interpersonal level was no smoking in social circles. So participants were reporting that people who don't have other smokers in their social circles are more likely to quit smoking. At the organizational level, one of the barriers was the lack of smoking cessation resources and the lack of targeted intervention for Latino smokers. Some of the facilitators was the first HIV care visit. Participants reported that this is a very important visit for participants to start receiving their HIV care, including medications, and this should be seen as an opportunity for helping them quit smoking. Another facilitator at the organizational level was culturally competent care, meaning when the team that were providing services were culturally competent, people were more likely to adhere to both their medications and their medical appointments. At the community level, one of the barriers was HIV and mental health stigma. HIV stigma was related, and some people were saying that when they were offering smoking cessation services at their clinic or organization, sometimes people don't want to go, especially when they have group counseling, because they're afraid of other community members knowing their HIV status. When it comes to mental health stigma, participants were reporting that Latinos living with HIV, they're not very likely to talk about mental health, and they're very private when it comes to their emotions. When it comes to the facilitator, they pointed that COVID-19 was an opportunity for smoking cessation. So this should be seen as a teachable moment for people to quit smoking. At the policy level, one of the barriers was paperwork for insurance, meaning that even though people living with HIV qualify for special and comprehensive insurance programs, the paperwork for them to get enrolled in these insurances, it is kind of difficult for them. So they do need help with that. And one of the facilitators was that these insurance programs were very comprehensive, including for smoking cessation. Participants were reporting that these insurance programs cover nicotine replacement therapies, varenicline, and bupropion for smoking cessation. So we should be taking use of these comprehensive insurance programs. So this is the presentation that I had for today. Thank you very much for listening. Muchas gracias. And here you have my email. Please email me if you have any questions. And I would like to give a special acknowledgement to my mentor, Dr. Ana Paula Cupertino, who I've been working with for the past 5 years. Thank you very much.
I'm Darren Mays from the Ohio State University Comprehensive Cancer Center. I'm happy to have this opportunity to talk with you today about cancer prevention with mobile messaging, including 2 examples from my research on melanoma prevention and tobacco control. I have no relevant financial relationships within the past 24 months to disclose. To start off, I want to give a disclaimer that the concept of leveraging mobile technology for health promotion and disease prevention is not a new idea. For example, the National Institutes of Health convened the first mobile or mHealth summit in 2009 to explore the use of mobile technologies to improve public health in the US and around the world. But I want to focus us on mHealth for cancer prevention with this quote from a recent paper by Judith Prochaska and others. The boom in mHealth has been made possible by high penetration of internet access and increased use of smartphones. mHealth technologies offer the ability to scale and engage entire populations, develop supported social networks, connect patients and providers, encourage adherence with cancer care, and collect vast quantities of data for advancing cancer research. In other words, these devices we carry in our pockets everywhere are extremely powerful tools for cancer prevention. So what makes this the case? These are data from the Pew Research Center on mobile phone ownership among US adults since 2004. The blue line displays the increase over time in any mobile phone ownership. And as you can see, now it's virtually all US adults that own a mobile phone. The yellow line displays smartphone ownership, that is Android and iPhone type devices, which has accelerated over the past decade to about 80% of US adults today. The table on the right breaks these trends out by social demographic characteristics. And I want to focus on a couple of these examples to highlight where there are notable differences in technology ownership. For example, by age, older adults are less likely to own smartphones than younger adults. And by geography, those residing in rural areas are less likely to own a smartphone than those in urban and suburban areas. I'll come back to this a bit later as we revisit this topic in a subsequent slide. When we think of interventions for cancer prevention, a relatively straightforward way of considering their impact in the population is through this formula from the RE-AIM framework, where reach, or the number of people in the population affected, times the intervention's efficacy equates to the impact in the target population. From this perspective, mHealth interventions for cancer prevention are positioned for very high impact because it's a technology through which effective interventions can reach so many. Another recent trend I'd like to highlight, pointing to the importance of mHealth interventions, comes from the healthcare sector. The past 14 months have been a unique experience, to put it lightly, because of living in the COVID pandemic. In our day-to-day lives, we've shifted how we work, how we monitor kids at school, and many other activities to technology-mediated communication. This figure from The Economist provides a bigger picture perspective in related shifts in the industry. Global digital health revenues from telemedicine, online pharmacies, wearable devices, and so on will rise from $350 billion last year in 2019 to more than $600 billion in 2024. The groundwork for what looks poised to be the next trillion-dollar business has been accelerated by the COVID-19 pandemic. I highlight this because despite long-standing interest in mHealth technology for health promotion and disease prevention, one potentially positive impact of the pandemic may be an acceleration in interest in developing solutions such as mHealth interventions for cancer prevention. So with that context, I'd like to highlight two examples of mHealth interventions from my own research in the area of melanoma prevention focused on indoor tanning and tobacco use focused on water pipe or hookah tobacco smoking. And at first glance, these may seem like very different behaviors, but there are in fact several similarities that lend themselves to the mHealth intervention approaches that we're studying. Both are established risk factors for cancer in ultraviolet radiation exposure and exposure to combustible tobacco smoking. Both are entirely preventable. Removing the exposure by helping people change their behavior reduces the cancer risk. Both are behaviors that tend to emerge or onset early in life, that is during adolescence and young adulthood. Both are addictive behaviors. Tobacco use, this is firmly established with nicotine as the addictive substance in tobacco. Indoor tanning, this is less well known, but there's a growing body of evidence indicating some young people become addicted to indoor tanning, and that's how my research approaches this problem. Both are behaviors where there's low motivation to change in young people. Both are also relatively infrequent behaviors. So when we think about something like cigarette smoking, which happens multiple times a day, indoor tanning and water pipe tobacco smoking are most typically weekly or monthly in frequency for young people. And both are behaviors where there's very little published intervention science. So we're starting from a fundamental point in the research and in terms of how we can intervene to prevent the cancer risks associated with these. So in the first example of our intervention research on indoor tanning that is supported by funding from the Prevent Cancer Foundation, our population is young adult women who meet research screening criteria for indoor tanning addiction. So this is a high-risk group from a behavior standpoint for melanoma and other forms of skin cancer. Our study design is a two-arm parallel group randomized controlled trial. We developed a mobile messaging intervention that's 4 weeks in duration, and during that time, participants receive text messages to their mobile phones on 2 days each week. This is in contrast to interventions, for example, for cigarette smoking, where it's much more typical to have multiple messages a day, for example. The content that we created for these messages, they're text messages, so just like text messages that you might receive or send to family or friends. In this case, we're sending content that's focused on communicating the risks of indoor tanning because we know that that's an issue where awareness is low. And we're providing content to enhance their motivation and support quitting. All of this is tailored or personalized to their initial readiness to change when they start the intervention. The outcomes that we're measuring in this study, two of the outcomes are cessation, if they quit, and motivation to quit. And in this case, I'll be presenting data on our 4-week outcomes at the end of the intervention. This is an interim presentation of interim findings because we're about halfway to our recruitment goal. We'll have longer term outcomes at a later date. So in the table, this displays the proportion of participants reporting quitting indoor tanning at the 4-week follow-up in the control group and in the intervention group. This is not quite a statistically significant difference, but what we're seeing in this interim sample is about twice as many participants in the intervention group are reporting quitting compared to the control group. We also measured, as I mentioned, motivation to quit indoor tanning, which is shown in the figure. As you can see, the red line is the control group. There's essentially no change from the baseline to the follow-up. But in the intervention group, we see a significant change in motivation to quit from baseline to the follow-up time point. So these are positive signals in an interim analysis as we're continuing to recruit for this study that our intervention, our mHealth intervention, is having the intended impact on indoor tanning behavior. The second example from my research is focused on water pipe or hookah tobacco smoking cessation, and this is work that's funded by a grant from the National Cancer Institute. Our population in this case is young adults who are current hookah tobacco smokers, and our study design is a 3-arm parallel group randomized trial. In this case, we have a control group that's receiving no intervention, and we tested 2 versions of our mobile messaging intervention. The first is called an untailored version, and what that means is all of the participants get the same exact content. And the second is a tailored intervention. So in the tailored intervention, that content is personalized to data that we collect at baseline, as well as text message exchanges that happen with participants during the intervention itself. Like the tanning study that I gave as an example, this intervention is 6 weeks long, and we're delivering messages on 2 days a week during that time. The content is slightly different. In this case, we're using what's called mobile multimedia message service messages. In plain language, what that means is text and images. So like the photos or other pictures you may send and receive from family members and friends, in this case, we're sending intervention content communicating the risks of hookah tobacco smoking in both text and a visual. And we're also including content that is aimed at motivation enhancement to support quitting. Our primary outcome in this study, among other outcomes that we measured, was cessation at 6 months. And we measured this at interim time points as well. So these are our data on cessation at a 6-month follow-up, which we analyzed in 2 ways. We had great retention in this study. We retained 91% of our participants at the 6-month follow-up, but we still looked at the data to account for attrition in our analyses. So when we analyzed the available data, that is only the people who completed the follow-up, cessation was significantly higher in the tailored intervention arm at 49% versus the control, which was 29%. When we assumed that all of the people who were lost to follow-up had continued smoking, cessation was still significantly higher in the tailored intervention arm at 43% versus the control arm at 28%. So this is another example of an efficacious, from our trial, mobile messaging intervention, in this case for water pipe or hookah tobacco cessation. These 2 examples from my research are what I would call, from a technology standpoint, relatively straightforward mHealth interventions. That's not to say they weren't a lot of work to create, to conduct the trials, to test. But what I mean by that is we're relying on native messaging apps to send and receive text messages with participants in these interventions. We're not yet using things like mobile applications or other technology that are available through these devices to potentially promote behavior change. Thinking about the background that I presented on mobile phone ownership and trends and how we can maximize the potential impact for mobile interventions, I want to conclude with 2 points about what kind of science we still need moving forward. The first point I want to leave with is focusing on efficacy. So recall from the REAIM framework that reach times efficacy equals impact. We have high reach with mobile devices. We need efficacious interventions to create impact for the cancer prevention behaviors that we're targeting. The first quote here is from a recent Cochrane review of the evidence for mHealth smoking cessation interventions. And the authors concluded that there's moderate certainty of the benefit of text messaging interventions, but the evidence comparing smartphone apps with less intensive support was of very low certainty, and more randomized trials are needed to test these types of interventions. The second quote is from a recent study that reviewed content of applications that are available to consumers now through the App Store on iPhone devices, the Android Store for Android devices. And these authors concluded that the vast majority of the mobile applications for behavior change that are available to consumers included a limited number of techniques to promote sustained behavior change. Although some of this evidence is from studies for cigarette smoking cessation, I believe they hold true, the conclusions hold true for other cancer prevention domains as well. The science on efficacy needs to be better developed, and what is available to consumers, for example, through the App Store and the Android Store, is predominantly not evidence-based. The second point I want to leave you with is to focus on equity. And so recall the data that I showed initially, demonstrating that although mobile phones in general are used by nearly all US adults, there are still some gaps. For example, when we consider smartphone ownership by specific demographic groups. This speaks to the need to address disparities both in technology use and in cancer-related behaviors in the science. In a recent commentary on this issue, Huen and Vishwanath stated that just as robust clinical trial evidence is critically necessary, consideration of how mHealth technology can be adapted and strategically delivered to the most vulnerable patients is of equal value. So the question is, how can we design and deliver our mHealth and other digital interventions in a way that addresses ongoing cancer disparities? The second quote is an example of the conclusions from a recent analysis by Michael Amato and Amanda Graham at the Truth Initiative, an organization that's one of the leaders in digital smoking cessation interventions in the US. They examined in a recent study registration over time to their Become an X program, a digital smoking cessation program over several years, and found that smokers from non-metro or rural areas appeared to seek out and use digital cessation resources during this time, and attributed it to broadband availability and increasing smartphone use in those populations. To me, this is a great example of intervention reach in a community that's traditionally affected by cancer-related disparities in rural communities. We know they're affected by higher smoking rates and smoking-related cancer, yet this evidence shows that they are receptive to and proactively engaged with digital and mHealth interventions, demonstrating that they can be impactful for reducing cancer disparities if they're thoughtfully designed and distributed to reach such groups. So I encourage those of us who are working in this space or interested in this space to consider how our interventions can be designed to leverage the technology that meets the needs of the target populations in an optimal way to enhance the impact on cancer prevention outcomes. I will stop there. I thank you for your time, and I look forward to discussing any questions or comments you might have. Thank you.
Hello, and as mentioned, my name is Meenal Patel. I'm a director at the Schroeder Institute at Truth Initiative. Today's talk will be on following a moving target, policy issues, and addressing emerging tobacco products. I wanted to share that I have no relevant financial relationships to disclose within the past 24 months. Today, I'm going to really talk about this overview of tobacco products, as well as understanding current tobacco use rates in adults and adolescents, as well as the proliferation in emerging tobacco products. We're also going to be discussing an overview of policies that affect these tobacco-related products, focusing on menthol and youth-centered flavors, as well as identifying gaps and loopholes in current tobacco policy. Finally, I have some recommendations for implications for future policy. So for many of you, you may know that youth tobacco use has been rising in previous years. However, we have good news. Youth cigarette use continues to decline in the United States. Youth e-cigarette use was at an all-time high in 2019, but has decreased since then. However, we still have some concerns. Total tobacco product use, including e-cigarette use, has increased in the United States amongst youth. We still have millions of young people vaping and at risk of addiction and becoming tobacco consumers for life. So when we look at adult smoking prevalence, we see that since 2010, we've had a great decline in smoking prevalence amongst all adults as well as young adults. However, amongst adults, you'll see that we are starting to see a tapering of reduction, and it's plateaued at 14%. Amongst youth, we've seen a great decline in current 30-day smoking from 27% in 1998 to only 3.3% in 2020. Now, if you look at multiple tobacco product use, you see that any tobacco product use was an all-time high in high school students in 2019, and e-cigarettes specifically were at a high of 27.5% of high school students using tobacco products, e-cigarettes, within the last 30 days. We did see a decline to 19.6 in 2020. However, I do want to point out that we are in the middle of an epidemic and a pandemic where adolescents have not been in a traditional high school setting. And many of the ways in which adolescents secure these products is through their peer influences. The reason that we're so interested in e-cigarette use and cigarette use is because nicotine exposure during adolescence is very important, as their brains are not fully developed until the age of 25. Nicotine can harm the developing brain and cause deficits in attention and cognition and mood disorders. E-cigarettes are really our primary source of nicotine for this age group, especially amongst high school students. Since their introduction in 2008, e-cigarettes have become both ubiquitous and an increasing source of public health and policy concern. And now they're starting to threaten the progress that we've had in public health over decades of reducing cigarette use. So we're interested in this specifically because e-cigarettes are now the most commonly used tobacco product in youth and young adults. And 70% of these youth e-cigarette users say they use them because they come in flavors that they like. We also see that young people are more likely to start smoking cigarettes if they're vaping, and that's 7 times more likely. So you may have heard of the first generation e-cigarette, and that was really meant to mimic a cigarette, which you can see in the first picture. However, over time, we're now at the 3rd, 4th generation of e-cigarettes, where we see these sleek devices, and they look very, very different than a traditional cigarette. They're a whole new product unto themselves. E-cigarettes or vapes produce an aerosol by heating a liquid that usually contains nicotine, flavorings, and other chemicals. And they can be harmful when inhaled and potentially have other harmful substances. Some of these common brands are shown here. You may be most familiar with Juul or Puff Bar or Vuse. The Juul influence is really important to understand. This is a product that entered the market in July of 2017. And between July 2017 and October 2018, the number of young adults between 18 to 21 who tried Juul increased more than 400%. And by November of 2018, Juul claimed 2/3 of the total e-cigarette market in the United States. Well, why is this important? Well, first, a Juul pod is equal to about 20 cigarettes worth of nicotine, as they have stated previously on their website. And many individuals who are Juul users didn't know, 63%, that these products contain nicotine. One innovative aspect of Juul is that nicotine salts were developed, and they're a complex compound containing salt-based nicotine. The reason it's important is it's less harsh to vape, which allows for better tolerance of higher nicotine salt e-juice. And every Juul pod contains 3 to 5% of nicotine, which is higher than most products that were previously on the market. And so one Juul pod contains approximately the equivalent of 20 cigarettes worth of nicotine. We really wanted to get an idea of understanding this role of nicotine and Juul specifically, and so we conducted 3 specific studies. The first was to understand Juul use and reasons for initiation among adult tobacco users, but then we wanted to get an idea of the impact of Juul on schools amongst teachers and administrators, as well as understanding parent perceptions of Juul and other e-cigarettes. And what we found was 44% of parents identified a Juul device as an e-cigarette, and while most parents, 96%, had seen or heard of e-cigarettes, only 55.9% had seen or heard of Juul, and only 44% could accurately identify an image of Juul. Now, this is very similar for teachers and administrators, and also relevant for other healthcare providers who definitely are supposed to, be helping this youth group in terms of reducing their tobacco use, but sometimes may not be aware of these products that are emerging on the market. And again, we are concerned about this in the United States because there is a risk for future combustible cigarette use. We know that there is substantial evidence that e-cigarette use increases the risk of ever using combustible tobacco cigarettes amongst youth and young adults in the United States, as said by the Public Health Consequences of E-Cigarettes from the National Academies of Science. Now, it's very important to understand that the climate in the United States is very different than the other countries that may be using e-cigarettes as a harm reduction tool. In the United States, this product has really been for being on the market as a product for any individual who may be interested in nicotine or an alternative to any product that may contain nicotine, including combustible cigarettes. However, in other countries, it's used as a cigarette cessation tool, and that can be very different in terms of the climate of this epidemic of adolescents using in the US, unlike other developed countries. We did a study examining smoking cessation amongst US adults and their use of Juul, e-cigarettes, and other products. And what we really found was that 78.8% of former smokers who quit in the past 4 years, were not at all using any of these products, but really only 3.6% of adult smokers who attempted to quit in the past year used Juul in any combination with other e-cigarettes or nicotine replacement therapy. And so what we're seeing here in the United States is very different. And it's important to understand our political climate and the tobacco policies that are put into place and how they may differ than other countries. But today, I'd really like to focus on tobacco policies as a tool for reducing the harm of tobacco use in adolescents. So some of the policy examples that I'll quickly run through are looking at either restricting e-cigarette flavors, having a low nicotine standard, briefly discussing the PACT Act, and e-cigarette tobacco retail licensing. But there are several other policies that can be put into place that would help restrict the use of tobacco products on the market. And we really want to focus on flavors with e-cigarettes specifically, because 97% of youth who vape have reported that they use flavored tobacco products. And 81% of youth who had ever tried tobacco chose flavored tobacco first as their first product. Now, it is beyond just e-cigarettes. So some flavored tobacco products can include hookah, cigars, smokeless products, and e-cigarettes. And flavors are really one of the main drivers of youth tobacco use. So if you look here, there are flavors of many e-cigarettes shown on the very top left. But on the right, we also see very affordable flavors and appealing flavors of cigarillos, which are thin cigars sold in sets of 3 for only 99 cents. And you can get them in fruit punch and raspberry cream. And these are very, very appealing to adolescents. We also are starting to see many smokeless products showing, various flavors coming onto the market. And the other concern about flavors is menthol has been used historically in many cigarette products, especially to those targeting underserved communities, specifically the African American community. And we know that nearly 9 in 10 African Americans use menthol cigarettes of those who smoke. That is very upsetting and disturbing because menthol is also a way to get adolescents to be more interested in using combustible cigarettes. And one of the reasons why it's appealing is because it reduces this harshness of smoke, and it also makes it easier to start, but also harder to quit. And the industry is very well aware of this. And so we have e-cigarette policies that, have been considered, but what we have seen is weak regulation results in weak results. So I'm going to run through a brief history of some of these e-cigarette federal level regulation highlights. In August of 2016, we had a deeming rule that was finalized, making it the first time the FDA had authority to regulate e-cigarettes. And in 2017, they announced that they would, have a regulation plan. The FDA started to crack down on some of this in 2018. And then I'm going to speak a little bit about the 2020 policy. But what we found was there were several gaps in this regulation. So compliance policy is incomplete and doesn't protect kids. We need FDA to review e-cigarettes on the market now, and FDA needs to enforce the law to the fullest. Finally, we need to ban flavors on all tobacco nicotine products, not just e-cigarettes, as well as prohibit the online sale of tobacco products. So here's a story of a policy that had a lot of promise. Most recently, in September of 2019, the Trump administration announced it would remove all flavored e-cigarettes from the market until FDA reviewed them and determined that flavor was appropriate for the protection of public health. This was thrilling news, and speaking as a researcher, also as an advocate, I was really happy to see flavors being removed because adolescents were the ones who were using these most in terms of Juul and other e-cigarettes. And so I put out a survey where we did a national sample of adolescents and young adults who were currently using e-cigarettes and asked them, if flavors were removed from the market, what would you do? Would you stockpile? Would you buy them off the black market? Would you create your own flavors? Would you stop using? Would you, switch to other tobacco products? And there was a lot of promise in these individuals reporting they would probably quit because they weren't so keen on the tobacco flavor of the e-cigarettes. And it wasn't really the nicotine that they were excited about, it was the flavors. However, the nicotine is what kept them going. Unfortunately, it didn't take long for the vaping industry to swoop in, and the administration began walking back on that very strong proposal. And very soon after, Donald Trump, who was in charge at the time, said that, they'd be meeting with representatives of the vaping industry. And what's unfortunate is prior to this, we had a meeting with the president to discuss our results and had shown quite a lot of promise in taking these flavors off the market. And so the final policy that was issued by the FDA on January 2nd, 2020, was looking at prohibiting all flavored closed system cartridges, such as menthol and tobacco flavors. They were no longer exempted from the ban. And so we were able to have flavors like mint and mango off the market, but menthol and tobacco was still kept on the market. And they continue to be sold in all types of e-cigarettes. And additionally, e-liquid flavors for open or refillable systems are still allowed. So it's really the pods that were being regulated. And disposable e-cigarettes of any flavor are still allowed. And there's no restrictions on where these products can be sold. And so here's a graphic representation of what's not allowed and allowed. If you look, Juul was the most popular, so those flavors were not allowed. But Juul actually voluntarily took off some of their flavors from the market prior to the implementation of this policy. However, look at all of the products on the right that are still available. And we see, menthol Juul pods, which are very similar to mint, still on the market. And we see this proliferation of disposables and other flavored products. If you look at the e-juice in the center, it really is highlighting gummy bears, which is very appealing to youth and less so to adult smokers who may be trying to quit e-cigarettes. And so going beyond Juul, we see that disposable vapes are now becoming more popular. So under this new federal policy regulating e-cigarettes, non-pod based e-cigarettes such as puff bars were exempt, creating this federal loophole for flavored e-cigarettes. And these disposable e-cigarettes use a very similar nicotine salt formulation for high and effective nicotine delivery. And so what have we seen? A rise of disposable e-cigarettes since this policy has been put into place, specifically for puff bar. So during 2019 to 2020, disposable e-cigarette use has increased over 1,000% among high schoolers and current e-cigarette users, and approximately 400% among middle schoolers. So puff bar is now the most popular disposable e-cigarette among young people. And in very many cases, people are saying it's now quickly becoming the new Juul. But we need to go beyond just puff bar and all of these products. We're constantly targeting new products coming onto the market. And these vaping flavor bans have paved the road for new oral tobacco products, or OTP. And they come in various different flavors. And so these products are for both snus and other flavored products that you keep in your mouth. And many times they say they're tobacco free because they just have the nicotine and they don't have the tobacco leaf in it. And it comes right now in several flavors, including mint and citrus. To get a little bit more of the idea of it, sometimes there is synthetic nicotine in these, which is not regulated by the FDA Center for Tobacco Products, or they have nicotine derived from tobacco leaf, but without the leaf itself. And they're in more acceptable formats, such as lozenges, pouches, discs, and gum. And this is more socially acceptable than traditional smokeless tobacco, where individuals would be spitting out the tobacco at some point. But this is concerning because it's now being targeted towards a younger and alternative audience rather than the traditional smokeless tobacco product market. In the interest of time, I won't get too much into these next few policies, but I did want to acknowledge that there are many other policy approaches. So one of the approaches that was mentioned a few years back was potentially having a low nicotine standard for combustible cigarettes. And now this product idea of policing the amount of nicotine in cigarettes has now been potentially proposed to be having a low nicotine standard in e-cigarettes as well. And the reason that we want to take a look at this is understanding, what do individuals actually know about nicotine and the health harms, and understanding the behavioral predictions. So you can read more about this in a paper that's referenced below. We also have the PACT Act, which is very important right now given the use of selling e-cigarettes on the market. And we see that they're being sold online. And so generally this would prohibit cigarettes and smokeless products from being sent through the mail. And this is something that will hopefully go into effect soon. Finally, there are ways to have e-cigarette tobacco retail licensing laws. And if you look at this, you see that in the United States, there are several states that do have TRL laws for e-cigarettes, and these laws can create structures for better enforcement and regulation of tobacco products, specifically of e-cigarettes. But we also have other policies that may actually be helpful in conjunction with that, such as restricting sales to minors under the age of 21, which is now a federal policy. So what are the future implications of this? Well, we really need more federal action. And here's what we think. that the FDA should be doing. They should be removing any products that don't comply off the market immediately. They shouldn't really be allowed on the market while they're assessing whether these products are safe or, whether they're helpful, et cetera, whether they have a potential to reduce harm. They should just be off the market. We need to extend marketing restrictions on cigarettes to e-cigarettes, so sponsors and self-service access and free gifts with purchase are no longer allowed. We need to restrict digital and social media marketing. There is a huge loophole that allows companies to unofficially market through social media and through influencers. And that is very dangerous for the group of individuals, adolescents and young adults who tend to use these social marketing platforms. We need to prohibit all non-face-to-face sales, including on internet sales, prohibit the sale of all flavors in all e-cigarette products, but really all products. Menthol should not be on the market because we know the disparities that it leads to. We need to require child-resistant packaging, restrict nicotine levels in e-cigarettes, develop nicotine cessation interventions, and fund research to better understand e-cigarette harms. There is hope. There are local policies that are leading this way. And as of March 31st of 2020, 293 jurisdictions had some type of restriction on flavored tobacco products, and that has only increased in the past year. And so local and state action gain momentum to address regulatory gaps and reduce availability and appeal for flavored tobacco products to youth and young adults. And so we need state and local action. They don't need to wait for the FDA to act. And what they can and should do is require all e-cigarette retailers to be licensed, prohibit the sale of all flavors in tobacco products, including e-cigarettes, and require e-cigarettes to be subject to clean indoor air laws. But really, it's this combination of multiple policies that's needed to reduce this use of tobacco products, and especially the fact that these products continue to change. It's not about Juul, it's not about Puff Bar. It's really about understanding these emerging products and how we can use policy to reduce the burden of tobacco on adolescents and young adults. Thank you.
Well, thank you very much to our three speakers for a fantastic set of presentations. I watched them earlier to prepare for this broadcast, and I was worried I'd be bored the second time around, but I wasn't at all. These were such rich conversations that they really held my interest a second time. To the audience, I apologize for the brief technical glitch, and I want to remind you that you can participate by putting questions and comments in the Q&A tab of the engagement tool on the right-hand side of your screen. The questions will be moderated, and we'll try to get to as many of them as possible. I also note that the slides will be posted by the Prevent Cancer Foundation, and I noticed several of the speakers had their contact information on one or more of their slides. So I imagine they would welcome a question or two from people that attended this. Nod your head if that's true, just to put you on the spot for a moment. And so now we're going to do a brief poll prior to starting the question and answer, where we learn a little about you and as an audience and your use of tobacco products, for example. So click the polls tab in the engagement tool on the right of your screen to answer and see the results. The question, have you ever used, and check all that apply, chewing tobacco, cigarettes, cigars, disposable e-cigarettes, e-cigarettes with closed systems, etc., hookah smoking, or I have never used any of these. We thought that would be interesting to see the results. So it jumps out at me that, almost half the people have used cigarettes, but half have never used any of them. And I note that my grandfathers both smoked, and my father was a lifelong smoker. And I smoked from when I was 13 to 35, when I was able to quit using the joint impetus of planning to become a father and a case of nicotine patches, which my uncle, who was a physician, supplied for me. But my sons are never smokers. So I think that really seems like progress and a reminder of the multi-generational and multi-decadal effort that's been needed and is continued to be needed to address tobacco control for public health. I also note that these talks epitomize the fascinating and frustrating dance in the United States between forces acting to improve public health and prevent cancer at the individual and policy level, and forces acting in ways that damage public health as a byproduct of the impetus for profit and through efforts to create demand for these products and supply that demand. So it's a subtle and long-term problem to deal with that feature of the American system, but we need to continue to do it because public health and health for all has great value. So my compliments to these researchers and to this whole community. So let me start out with some questions from the audience. I wonder how has the pandemic impacted e-cigarette use among adolescents and children? Who would like to take that one? Minal, maybe to start with?
Yeah, I'd love to answer briefly in saying that we actually recently tracked the use of adolescents on e-cigarette use pre-COVID for about up to COVID, because we had that data, and then 3 months post, and we'll be publishing our results in the American Journal of Public Health very soon in the next month or so. But we did see that, their normal access to use has been taken away, which was a lot of their peers, and they were getting it at schools or in school settings. However, we also don't know what's going to happen as schools start to open up again. So this was a snapshot in time of pre-COVID, post-COVID shutdowns. However, we have seen, looking at the NHS data that I presented, the rates did go down from 27.5% in high school students in 2019 to about, 19% in 2020. And so we do see a reduction. I don't know if this reduction will last. I don't know if it's because of all of the great efforts in public health that we've made, or if it's a blip in terms of the pandemic. So, time will give us the answer to that.
Thanks, Minal. Darren, it seems like these digital interventions are effective and highly appealing. They can work in diverse settings and for diverse ages. Could you talk a little bit more about, the path from research to making these interventions available, and whether there are ones available for adolescents as well as adults, and maybe the three-part question,
Sure.
what can I just download an app on my phone and it will be great, or what's the process here?
So I think there are a couple of layers to that. As I spoke about briefly, current state of things that are available through, for example, the App Store or the Android store, it seems like those are probably not the highest quality products in terms of the evidence base that supports them. I think there are organizations that are that are at the forefront of this. So David, one being the National Cancer Institute and the resources that NCI makes available through smokefree.gov in terms of online and text messaging programs. Another being the Truth Initiative and digital smoking cessation resources that are available, not just smoking, also vaping cessation resources that are available through Truth Initiative. I think from a research standpoint, at least for me, one of the things that I think is fascinating and still not well answered is what I would call kind of the field of dreams question. Like, we spend all this time building these interventions like the ones that I presented, and then, at some stage in the process, either while we're developing and testing them or once we've established efficacy, a really important next step is when we make those available to people, in my case, the target audience is typically young adults. That's a group that I focus on. How can we sort of advertise and promote them in a way that increases uptake and engagement? And I think that's an important question. It depends on the audience and the target population, but it's a key piece to that puzzle in terms of population impact when we have these types of scalable interventions available.
Thank you. For researchers in the audience, I would commend the NCI Office of Implementation Science, which has a variety of resources and funding opportunities relating to dissemination and implementation of interventions for cancer control. Francisco, I noticed you mentioned working with a community advisory group, and we've had a series of workshops over the past year in obesity and other areas with repeated calls for wider use of such groups. I don't know for a fact, I know CDC mandates the use of such groups. I don't know how many NIH grants sort of end up using such advisory groups. But since people are calling for their use, I have a feeling there's a gap there. So could you talk a little bit about the benefits of an advisory group for your research and maybe some of the challenges as well associated with the time commitment and energy required to form such a group and work with it?
That's a really good question, David. Thank you. So yes, the work that we do is based on participatory research methods, and we convene an advisory board. And we included this advisory board when we were designing the intervention. And just to give you an example, they were the ones who endorsed the use of nicotine replacement therapies. This was because they know that they're effective, they know the cost about it, they're available without prescription, and they have minimal contraindications and side effects. So they were the ones who endorsed us to use nicotine replacement therapies. Now, when it comes to developing the intervention in Spanish, we know that there are some regional differences in Spanish. For example, the Spanish that people may use in the Dominican Republic is different from the one they use in Mexico, the one they use in Argentina. So we made sure that the members of the advisory boards were from different Latino nationalities. So they were reviewing the messages one by one, making sure to have like a universal Spanish, if you want to call it like that. And not only making sure that the Spanish was appropriate for all Latino nationalities, but also making sure that the messages were culturally appropriate. For example, including lots of family values. And one other example, they were the ones who have guided the recruitment of the studies. We have partnered with people from marketing. And just to give you an example, we had a member of the advisory board who was part of Univision, which is a large television, so who serves Hispanics. And they were more than happy to include us in their advertisement. And that was the most effective recruitment method. We have also partnered with people from education. So every time there was like a parent night, they would invite us to recruit people, and that was also very effective into bringing people into their studies. So lots of advantages. Like you said, it is time consuming, but I think it pays off. Again, the fact that they provide their valuable insights and they guide the recruitment, the development of the intervention, that's very valuable.
Thank you. I think the recruitment issue is incredibly important because the major cause of difficulties in NIH-funded grants is are difficulties, delays, or slow recruitment. So that's a profound selling point for I think the whole community. Could someone comment on the issue of whether or not research has shown a link between cancer and vaping and e-cigarettes? I know that they've been pointed to as having lower levels of harm, and that might be an argument for efforts to switch. So could you talk about their relationship to cancer, but also maybe whether that argument switch to e-cigs and everything will be better even if it's not perfect? Maybe, I don't know who wants to talk about that. Maybe everyone, because that's a complex set of thoughts that needs to be unpacked.
I can briefly start off and have Darren and Francisco join in, but we know that combustible use is related to cancer, and we know that the rates of cancer are directly tied to it. So combustible tobacco is very dangerous. Now, e-cigarettes are a new product on the market, but one of the concerns that we do have is that people are using multiple tobacco products, including switching from e-cigarettes to combustibles, etc. Now, one of the issues that we are concerned about is we don't know what's in the e-liquid in e-cigarettes, and it isn't properly regulated yet. So if you were to buy a strawberry flavored pod and it's not Juul, but it's some other company, it may have a very, very different formulation than the mango flavored that comes from the same company. We don't know what's in them, so we don't know how carcinogenic all these elements are. But I will say, overall, combustibles are what we're most concerned about, right? However, in some countries, they may be using e-cigarettes for cessation purposes. In the United States, they are not regulated by the FDA to do so.
Thanks. We're just running out of time. Darren or Francisco, did you have any quick further comments to add on that question?
Not much to add, no.
Okay.
That was a good summary.
Fantastic. Thanks, Manal. And so I want to thank everyone again and thank the audience. I don't have anything profound to add in terms of conclusions, but I just want to say that tobacco remains this top challenge for cancer prevention and health promotion, and efforts in this area have fantastic benefits for public health. And I think tobacco control remains a priority for NCI and clearly for the Prevent Cancer Foundation. So keep up your good work. And I'm sure many of the audience members are involved in tobacco control. So my hat's off to your efforts in this area. Thank you very much.
Thank you.
Thank you.